Welcome to my workplace at Ranaghat, West Bengal, India. Let us observe this surgery where the people became small during nucleus management. At this time, the size of the people is okay. The people has dilated to about 5 millimeter or 5.5 millimeter. So it should not be a problem to manage this case if the people remains, if the size of the people is maintained. Let us see what happens. The main incision and a side port has been made. An air bubble has been injected into the anterior chamber. This is a minimally edited surgery. We will see the portion of this surgery, nucleus management part, real time. The other part is 33% more than the normal speed. And now this is, the anticapsule has been stained with trypan blue dye, visco, and rhexis. We will be able to do an adequate sized rhexis. So the Utrata forceps is being used. The capsular tag is guided along the border of the pupil to get an adequate size rhexis of about 5.25 millimeter. Hydrodissection is done, the nucleus is tapped, the nucleus is mobilized, visco again. And now the handpiece is taken, and from here we are going to see the surgery real time. As the handpiece goes into the anterior chamber, it rubs on the anterior surface of the iris, and the pupil starts becoming small. And at this time, the size of the pupil is less than 4 millimeter, maybe 3.5 millimeter. So what I do is I hold the nuclear mass and do direct vertical chop. Come to the other side. I have got a good crack, and I have got, I have divided the nucleus into two parts. One part, this part is bigger than the other part. Now this part is subdivided into two parts. Again, a vertical chop. And now I start emulsifying the pieces. At this time, the size of the pupil is about 2.5 millimeter, and I asked for iris hooks, but I find that it is not there. V-hex is also not there. I am operating at its peripheral center. And now I managed on piece, rotate and get the other piece. Yes, I have detached the epinuclear shell, and the epinuclear shell is also getting emulsified a bit. And now this is the nucleus. Yes. The other heminucleus is under the iris. Rotate, get the inner edge, hold it, chop, and emulsify. At this time, the size of the pupil is becoming smaller and smaller. It is 2.5 or 2 millimeter. But we can manage if the nucleus is not very hard. If the nucleus is very hard, it will have a very tough time. If the nucleus is hard, we should see that we must check that something is there in the operation room, either B-hex or at least iris hooks. And now I have used an oi hook, and I find that lot of cortex is there all around. And I have taken this 23G Simcoe, and I go under the iris. One thing we have to develop is proprioception. We have to have a sense of develop a sense of position of where something is. And we cannot see, but we know that it is there, and our hand must go to that place where our brain instructs to go, where our mind instructs our hand muscles to go. So that is, we have to develop. Now, I am implanting the intraocular lens at this time. The lens goes in the capsular bag. Some more visco, and I am going to check if there is some more cortex there at 12 o'clock. Yes, it is there. Some subincisional cortex is there. So I have made a side put at 7 o'clock, and my plan is to go through that side port and remove this cortex, which is subincisional. I have removed some visco from behind the lens, and now I go through the side port, and here it is. I am removing the cortex which is subincisional. It has come. So some cortex we can remove after implanting the intraocular lens. And now another check, if there is anything left, any cortex anywhere. This eye hook is very important. It helps us to retract the iris very well. Sinski hook is not a good instrument to retract the iris. This eye hook strides the pupillary border, and we can check very nicely if some cortical matter is left anywhere. And this is cleaning of visco. The visco is nicely cleaned. We have cleaned visco from behind the intraocular lens. We have cleaned visco from AC, from antechamber angle, from everywhere. This is closure of the side ports. The main wound will not require any hydration, but the side ports require a bit hydration for its closure, for their closure. This is the final lavage of the anterior chamber. The antechamber is nicely formed, and the case is concluded. Let us see some post-op pictures next day morning. The cornea is clear, antechamber is quiet, pupil is round, and the patient is having 6/12 unaided vision. Thank you very much for your attention. Hope this video will help you in developing your surgical skill. It will help you in managing small pupil cases when you don't have iris hooks or a pupil expansion device.